Okay, chapter 24, Iggy, Care of Patients with Cancer by Linda Workman. Learning Outcomes. Safe and Effective Care Environment. 1. Apply the principles of asepsis to protect neutropenic patients. Modify the environment to protect patients who have thrombocytopenia. Use personal protective equipment. Use personal protective equipment when administering chemotherapy or when handling excreta of patients within 48 hours of receiving chemotherapy. Coordinate with the healthcare team to adjust the environment for protection of the patient having photodynamic therapy. Health promotion and maintenance. Teach patients and family members how to avoid injury and infection when blood counts are low. Teach patients and family members skin protection measures for radiation therapy and photodynamic therapy. Teach patients and family members the proper scheduling and antiemetic therapy to ensure prevention or relief of chemotherapy-induced nausea and vomiting. Psychosocial integrity. Use effective communication when teaching patients and family members about what to expect during tests and therapeutic procedures. Encourage the patient and family members to express their feelings about the diagnosis of cancer, its prognosis, and treatment. Assess the patient's and family's use of coping strategies related to cancer treatment, possible role changes, and possible outcomes of the disease and its treatment. Teach patients strategies to improve body image changes that occur as part of cancer treatment. Physiological integrity. Correctly interpret laboratory data and clinical manifestations to determine the presence of cancer treatment side effects and oncologic emergencies. Prioritize nursing interventions for the patient with neutropenia. Prioritize nursing interventions for the patient with thrombocytopenia. Prioritize nursing care for the patient with radiation-induced skin problems. Ensure personal safety when working with patients receiving brachytherapy radiation. Prioritize nursing care for the patient with mucositis. Explain the rationale for hormonal manipulation therapy. Discuss the uses of biological response modifiers as supportive cancer therapy. Explain the basis of targeted therapy for cancer. Identify patients at risk for oncologic emergencies. Teach patients and families the manifestations of oncologic emergencies and when to notify the healthcare provider. As discussed in Chapter 23, cancer is a common health problem in North America. Most people fear cancer and consider a cancer diagnosis to involve suffering and death. In affluent countries, more than 50% of people diagnosed with cancer are cured, and thousands of others live 5 years or longer after the diagnosis. Regardless of treatment type, cancer always affects a person's physical and psychological functioning. Providing care to patients and families experiencing cancer is complex and challenging. This chapter describes the general interventions for cancer and the problems associated with cancer treatment. For specific treatment regimens and patient problems that occur with specific cancer types, consult the chapters in which the cancer is described. Table 24.1 lists common cancer types and the specific locations within the text where the interventions are presented. General disease-related consequences of cancer. As discussed in Chapter 23, cancer can develop in any organ or tissue but tends to occur more commonly in some tissues than in others. Cancer destroys normal tissue, decreasing function in that tissue or organ. Even when cancers occur in non-vital tissues or organs, they can cause death by metastasizing or spreading into vital organs and disrupting critical physiologic processes. See Chapter 23. Cancers that are left untreated cause reduced immunity and blood-producing functions, altered GI structure and function, motor and sensory deficits, decreased respiratory function. These impairments These impairments cause great physical and emotional distress. Without intervention, cancer invasion of normal tissues leads to death. Table 24.1. Text location of specific cancer content. Okay, well, let's look at that. Reduced immunity and blood-producing functions. Impaired immune and hematopoietic function occurs most often in patients with leukemia and lymphoma, but also can occur with any cancer that invades the bone marrow. Tumor cells enter the bone marrow and reduce the production of healthy white blood cells, which are needed for normal immune function. Thus, patients who have cancer, especially leukemia, are at an increased risk for infection. When cancer invades the bone marrow, it also causes anemia by decreasing the number of red blood cells and causes thrombocytopenia by decreasing the number of platelets. These changes may be caused by the cancer itself, such as in leukemia, or by the cancer treatment, especially chemotherapy. In either case, the patient has weakness and fatigue and is at risk for excessive bleeding. Altered GI structure and function. Cancer can alter GI function and impair nutrition. For example, tumors may obstruct or compress structures anywhere along the GI tract, reducing the patient's ability to absorb nutrients and eliminate wastes. Tumors often also increase metabolic rate and increase the need for protein, carbohydrates, and fat at a time when the patient has less energy for meal preparation or eating. Many tumors spread to the liver, profoundly damaging this organ. The liver has many important functions in metabolism. Reduced liver function leads to malnutrition and death among patients with cancer. Many patients with cancer have anorexia that often interferes with their ability to meet energy needs. Cachexia, or extreme body wasting and malnutrition, develops from an imbalance between food intake and energy use, increased catabolism. This problem may occur even when nutritional intake appears adequate. Changes in taste can result from the cancer or the treatment and reduce appetite. Nutritional support for the patient with cancer, especially one undergoing cancer therapy, is complex and controversial. A diet high in protein and carbohydrates is often prescribed to help him or her maintain weight and to provide the nutrients needed for energy and cellular repair. However, some scientists believe that an excessive intake of protein and vitamins increases the nutrition of the cancer cells and contributes to cancer progression. Patients often believe their cancers can be cured more easily if weight is gained or maintained. Currently, no one nutritional plan meets the needs of all patients with cancer. Motor and sensory deficits. Motor and sensory deficits occur when cancer invades bone or the brain or compresses nerves. In patients with bone metastasis, the primary cancer started in another organ, e.g. the prostate, breast, or lung. The bone sites most often affected are the vertebrae, ribs, pelvis, and femur. The humerus, scapula, sternum, skull, and clavicle are also common sites of cancer spread. Bone metastasis causes pain, fractures, spinal cord compression, and hyperkalemia, each of which reduces mobility. The patient may have sensory changes if the spinal cord is damaged by tumor pressure or if nerves are compressed. Sensory, motor, and cognitive functions are severely impaired when the cancer spreads to the brain. Brain metastasis and primary brain tumors also destroy healthy brain tissue, a major cause of cancer death. The patient with cancer may also have pain. Pain does not always accompany cancer, but it can be a significant problem for those with terminal cancer. The concept mapped on page 416 presents nursing care issues regarding cancer pain. Chapter 5 provides an in-depth discussion of the causes and management of cancer pain. Decreased respiratory function. Cancer can disrupt respiratory function and gas exchange in several ways and often results in death. For example, tumors in the airways can cause airway obstruction. If lung tissue is involved, lung capacity is decreased. Tumors can also press on blood and lymph vessels in the chest, blocking blood flow through the chest and lungs and resulting in pulmonary edema and dyspnea. Tumors can thicken the alveolar membrane and damage pulmonary blood vessels, reducing gas exchange. Thus, with lung cancer or the spread of cancer from other areas into the lungs, patients have hypoxia and poor tissue oxygenation. Cancer management. The purpose of cancer management is to prolong survival time or improve quality of life. Although a few spontaneous regressions of cancer have been reported, most patients would die within months of diagnosis without cancer therapy. Therapies for cancer include surgery, radiation, chemotherapy, hormonal manipulation, photodynamic therapy, immunotherapy, gene therapy, and targeted therapy. These therapies may be used separately or more commonly in combination to kill cancer cells. The types and amount of therapy used depend on the specific type of cancer, whether the cancer has spread, and the health of the patient. Treatment regimens or protocols have been established for most types of cancer. These regimens are based on experiments with cancer cells and animals and on experience with other patients with cancer. Surgery. Overview. Surgery is the oldest form of cancer treatment and was the first method to cure cancer. Surgery for cancer involves the removal of diseased tissue. If cancer is confined to the removed tissue, surgery alone can result in a cure for that cancer. Although many cancers have spread too far at the time of diagnosis for surgery alone to cure, it may still be a useful part of diagnosis, treatment, follow-up, and rehabilitation. Cancer surgery may be used for prophylaxis, diagnosis, cure, control, palliation, determination of therapy effectiveness, and reconstruction. Prophylactic surgery is the removal of at-risk tissue to prevent cancer development. It is performed when a patient has either an existing pre-malignant condition or a known family history that strongly disposes the person to the development of a specific cancer. An example of prophylactic surgery would be a pre-malignant condition. For a pre-malignant condition is removing a benign mole from a location where continuous irritation or exposure to sunlight occurs. Diagnostic surgery or biopsy is the removal of all or part of a suspected lesion for examination and testing. It provides proof of the presence of cancer. Curative surgery is focused on removal of all cancer tissue. Surgery alone can result in a cure rate of 27 to 30% when all visible and microscopic tumor is removed or destroyed. Cancer control or cytoreductive surgery is removing part of the tumor and leaving a known amount of gross tumor. It is also known as debulking surgery and alone cannot result in a cure. It decreases the number of cancer cells and increases the chance that other therapies can be successful. Palliative surgery is focused on improving the quality of life during the survival time and is not focused on cure. Examples include removal of a tumor tissue that is causing pain, obstruction, or difficulty swallowing. The specific procedure used depends on the patient's specific problem. Second look surgery is a re-diagnosis after treatment. The purpose is to assess the disease status in patients who have been treated and have no symptoms of remaining tumor. The results of this surgery are used to determine whether a specific therapy should be continued or discontinued. This type of surgery is most commonly used with ovarian cancer. Reconstructive or rehabilitative surgery. Reconstructive or rehabilitative surgery increases function, enhances appearance, or both. Examples include breast reconstruction after mastectomy, replacement of esophagus after radiation damage, bowel reconstruction, revision of scars, release of contractures, and placement of penile implants. Side effects of surgical therapy. Unlike surgery performed for many other reasons, cancer surgery involves the loss of a specific body part or its function. Sometimes whole organs are removed, such as the kidney, lung, breast, testes, arm, or tongue. Any organ loss reduces function. The amount of function lost and how much the loss affects patients depend on the location and extent of the surgery. Some cancer surgery results in major scarring or disfigurement. Patients may be anxious about the chances of surviving the cancer and also may be grieving about a loss of body image or a change in lifestyle. Patient-centered collaborative care. The physical nursing care needs of the patient having surgery for cancer are similar to those related to surgery for other reasons. See Chapter 16, 17, 18. For cancer surgery, two additional priority care needs are psychosocial support and assisting them to achieve or maintain maximum function. At times, major cancer surgery occurs within days of the diagnosis, before the patient and family have time to adjust. Assess the patient's ability and the ability of the family and significant others to cope with the uncertainty of cancer and its treatment and with the changes in body image and role. For example, surgery involving the genitals, urinary tract, colon, and rectum may permanently damage these organs, resulting in changes in the patient's means of sexual expression or control of elimination. Procedures to create a urinary or fecal diversion, e.g. a colostomy, may damage nerves, causing erectile dysfunction in men and painful intercourse in women. Removal of lung permanently reduces the patient's respiratory capacity and forever limits his or her ability to engage in physical activities. Coordinate with the healthcare team to provide support for the patient and family. Encourage the patient and family to express their feelings and concerns. Help the patient accept changes in body image by encouraging him or her to look at the surgical site, touch it, and participate in any dressing changes or incisional care required. Provide information about support groups such as those sponsored by the American Cancer Society or specialty cancer organizations. In addition to patient support groups, many of these organizations have separate support groups for spouses and children of the person with cancer. Discuss with the patient the idea of having a person who has coped with the same issues come for a visit. Such visits can be valuable in showing the patient that many aspects of life can be the same after cancer treatment. If the patient is open to this type of support, coordinate the arrangements for such a visit to the hospital or to the patient's home. Reduced function may be an outcome of some types of cancer surgery. For example, a modified radical mastectomy for breast cancer can lead to muscle weakness and reduced arm function on the side of the surgery. Participation in specific exercises after surgery can minimize functional loss. These exercises can be painful, and the patient needs encouragement to perform them. Teach the patient about the importance of performing and progressing the intensity of the exercises to regain as much function as possible and prevent complications. Coordinate with the physical therapist, occupational therapist, and family members to plan strategies individualized to each patient to regain or maintain original function. Radiation therapy overview. The purpose of radiation therapy for cancer is to destroy cancer cells with minimal exposure of the normal cells to the damaging actions of radiation. The effects of radiation are seen only in the tissues in the path of the radiation beam. Thus, this type of therapy is a local treatment. For example, radiation to the chest for breast cancer or lung cancer causes skin changes and hair loss only on the area of the chest only on the area of the chest actually being irradiated. Person does not lose his or her scalp hair. Some effects are apparent within days or weeks, whereas other effects may not be apparent for months to years after radiation therapy is completed. Most radiation therapy for cancer is ionizing radiation. When cells are exposed to this type of radiation, atoms within the cells are kicked out of orbit, resulting in a tremendous release of intracellular energy. Ionizing radiation is given off by many elements, including radium and any element with an atomic number above 93. In addition, most other elements have isotopes, a different form of a specific element that has a slightly different atomic weight and number of neutrons, that also are radioactive. For example, a radioactive isotope of cobalt is used in radiation therapy for cancer. Other radioactive isotopes are used in many diagnostic tests and nuclear medicine procedures. As a radioactive element breaks down or decays, radiation energy is released in the form of high-energy particles, alpha particles and beta particles, and high-energy photons, gamma particles. X-rays are radiation that is generated by a machine. X-ray photos and X-ray photons and gamma-ray photons are identical in their effects on cells. However, standard diagnostic X-rays use less intense doses and cause minimal cell damage. Cells damaged by radiation either die outright or become unable to divide. Radiation damage can occur anytime a cell is exposed to radiation and is not confined to cells actively dividing. However, cells in the cell cycle have more damage when exposed to radiation than do non-dividing cells. 3 different types of energy, or rays, are produced from radioactive elements: gamma rays, alpha particles, and beta particles. These energies vary in their ability to penetrate tissues and damage cells. Figure 24.1 shows the penetrating ability of each. Gamma rays are used most commonly for radiation therapy because of their ability to deeply penetrate tissues. Beta particles have much less ability to penetrate tissues and must be placed within or very close to the cancer cells to be effective as cancer therapy. See discussion of brachytherapy on page 419. Alpha particles are not used as part of radiation therapy for cancer. The amount of radiation delivered to a tissue is called the exposure. The amount of radiation absorbed by the tissue is called the radiation dose. The dose is always less than the exposure. 3 factors determine the absorbed dose: intensity of exposure, duration of exposure, and closeness of the radiation source to the cells. The intensity of the radiation decreases with the distance from the radiation source. This factor is known as the inverse square law. For example, the radiation dose received at a distance of 2 feet from the radiation source is only 1/4 of the dose received at a distance of 1 foot from the radiation source. The dose of radiation received at 3 feet is only 1/9 of the dose received at 1 foot. In theory, if the dose of radiation is high enough, all cells are killed immediately. This does not usually happen with cancer radiation therapy because all cells within a tumor absorb the radiation dose slightly differently. Therefore, their overall response to the radiation is slightly different. A A few cells die immediately, and more die within the next 24 hours as they attempt to divide. Some cells become sterile as a result of this single treatment. Still other cells repair the radiation-induced damage and recover. Radiation therapy usually is given as a series of divided doses because of the varying responses of all cancer cells within a group or within a given tumor. Small doses of radiation are given on a daily basis for a set period of time to allow greater destruction of cancer cells while reducing the damage to normal tissues. The total dose of radiation needed depends on the size and location of the tumor and on the radiation sensitivity of the tumor and surrounding normal tissues. Some normal tissues are more sensitive than others to radiation. For example, healthy breast tissue can tolerate much higher doses of radiation than can the liver. A total dose of 5,000 to 6,000 rad, or radiation absorbed dose, might be prescribed for breast cancer total dose. Only 1,200 rad might be prescribed for a primary liver tumor. However, because a higher dose would destroy the liver as well as the tumor, sorry, that's a messed up sentence. Only 1,200 rad might be prescribed for a primary liver tumor, however, because a higher dose would destroy the liver as well as the tumor. Okay. Radiation delivery. Two types of delivery are used for cancer therapy: teletherapy and brachytherapy. The type used depends on the patient's general health and on the shape, size, and location of the tumor to be irradiated. The ideal radiation dose is one that can kill the cancer cells with an acceptable level of damage to normal tissues. Damage to normal tissues cannot be avoided. Teletherapy is distant treatment. In teletherapy, the radiation source is external to the patient. Because the source is external, the patient is not radioactive and is not a hazard to others. The exact location of the tumor is determined for greater accuracy of radiation therapy. Once the pattern of radiation delivery is determined, the patient must always be in exactly the same position for all treatments. Ensure that the patient can get into and maintain this position. Position fixing devices and markings, either on the patient's body or on the devices, ensure the proper position each day of treatment. These markings may be small permanent tattoos or may be ink outlines. Brachytherapy means short or close therapy. With brachytherapy, the radiation source comes into direct, continuous contact with the tumor tissues for a specific period of time. This method provides a high dose of radiation in tumor tissues and a limited dose in surrounding normal tissues. Brachytherapy uses radioactive isotopes either in solid form or within body fluids. Isotopes can be delivered to the tumor tissues in several ways. With all types of brachytherapy, the radiation source is within the patient. Therefore, the patient emits radiation for a period of time and is a hazard to others. When the isotopes used are unsealed and suspended in a fluid, they are given via the oral or IV routes or instilled within the body cavities. An example of brachytherapy with soluble isotopes is the ingestion or injection of the radionuclide iodine. It's an iodine base with a half-life of 8.05 days to treat some thyroid cancers. The radioactive iodine concentrates in the thyroid gland and destroys the thyroid cancer cells. When the isotopes are unsealed, they enter the body fluids and eventually are eliminated in waste products, which are radioactive and should not be directly touched by other people. Once the isotope is eliminated, neither the patient nor the body wastes are radioactive. Most of this isotope is eliminated within 48 hours. Radioactive dookie. Okay, solid or sealed radiation sources are implanted within or very near the tumor. These radiation sources can be temporary or permanent. Most of the implants emit continuous low-energy radiation to tumor tissues. Some devices, e.g. seeds or needles, can be placed into the tissues and stay in place by themselves. Other sources must be held in place with special applicators. Some of these devices are so small and the half-life of the isotope is so short that the device is permanently left in place, most often for prostate cancer, and does not pose a hazard to other people. Other devices are removed and reused in other patients. With solid implants, the patient emits radiation while the implant is in place, but excreta are not radioactive and do not pose a hazard to anyone. Traditional implants deliver low dose rates, or LDR, of radiation continuously, and patients are hospitalized for several days. High dose rate, or HDR, implant radiation is another delivery type. The patient comes into the radiation therapy department several times a week, and a stronger radiation device is placed for only an hour or so each time. The patient goes home between treatments and is radioactive only when the implant is in place. Chart 24.1 lists the best practices for care of the patient with sealed implant radiation sources and for the safety of the personnel providing the care. Side effects of radiation therapy. Side effects of radiation therapy. The immediate and long-term side effects of all types of radiation are limited to the tissues exposed to the radiation. Therefore, the side effects vary according to the site. Skin changes and hair loss are local but are likely to be permanent depending on the total absorbed dose. Depending on the dose, altered taste, sensations, and fatigue are two systemic side effects, often noted by patients receiving external beam radiation, regardless of the radiation site. Okay. Taste changes are thought to be caused by metabolites released from dead and dying cells. Many patients develop an aversion to the taste of red meats. Fatigue may be related to the increased energy demands needed to repair damaged cells. Regardless of the cause, patients are surprised by the degree of fatigue they have and the need to adjust their lifestyle to manage this symptom. Radiation damage to normal tissues during cancer therapy can start the inflammatory responses that cause tissue fibrosis and scarring. These effects may not be apparent for many years after radiation treatment. For example, women who receive HDR therapy for uterine cancer may develop radiation-induced changes in the colon, which also was irradiated years later, resulting in constipation and obstruction. Patient-centered collaborative care. Most patients are anxious about radiation and look to the nurse to explain the purpose and side effects of radiation therapy. When patients receive accurate, objective information regarding radiation therapy, they are better able to cope with the treatment and continue to participate in normal activities. Chart 24.1, Best Practice for Patient Safety and Quality Care. Care of the patient with sealed implants of radioactive sources. Assign the patient to a private room with a private bath. Place a caution radioactive material sign on the door of the patient's room. If portable lead shields are used, place them between the patient and the door. Keep the door to the patient's room closed as much as possible. Wear a dosimeter film badge at all times while caring for the patient with radioactive implants. The badge offers no protection but measures a person's exposure to radiation and should be used by only one person. Wear a lead apron while providing care. Always keep the front of the apron facing the source of radiation. Do not turn your back toward the patient. Pregnant nurses should not care for these patients. Do not allow pregnant women or children younger than 16 to visit. Limit each visitor to one half hour per day. Be sure visitors are at least 6 feet from the source. Never touch the radioactive source with bare hands. In the rare instance that it is dislodged, use a long-handled forceps to retrieve it. Deposit the radioactive source in the lead container kept in the patient's room. Save all dressings and bed linens until after the radioactive source is removed. After the source is removed, dispose of dressings and linens in the usual manner. Other equipment can be removed from the room at any time without special precautions and does not pose a hazard to other people. Skin, and then back to the text. Skin in the path of radiation becomes very dry and may break. Teaching patients about skin care needs during radiation therapy is a priority nursing intervention. Chart 24.2. Chart 24.2 lists skin care and other precautions needed for external radiation therapy. Instruct the patient not to remove any temporary ink markings when cleaning the skin until the entire course of radiation therapy is completed. Instruct patients not to use lotions or ointments in these areas unless the radiologist prescribes them, because skin in the radiation path is more sensitive to sun damage. Advise against direct skin exposure to the sun during treatment and for at least 1 year after completing radiation therapy. The normal tissues most sensitive to external radiation are bone marrow cells, skin mucous membranes, hair follicles, and gonadal, or reproductive tissues. When possible, these tissues are shielded from the radiation during therapy. At times, however, they are in the path of radiation and cannot be adequately protected from exposure. Some changes caused by radiation are permanent. The long-term problems vary with the location and dose of radiation received. For example, radiation to the throat and upper chest can cause difficulty in swallowing. Head and neck radiation may damage the salivary glands and cause dry mouth, or xerostomia, and increase the patient's lifelong risk for tooth decay. Bone exposed to radiation therapy is less dense and breaks more easily. Teach about the types of symptoms that might be expected from the location and dose of radiation received. See Table 24.1 for location of this information. For the location of this information for different cancer types. Okay. Chart 24.2, Patient and Family Education Guide, Skin Protection During Radiation Therapy. Wash the irradiated area gently each day with either water or a mild soap and water as prescribed by your radiologist. Use your hand rather than a washcloth to be gentler. Rinse soap thoroughly from your skin. If there are ink or dye markings that indicate exactly where the beam of radiation is to be focused, take care not to remove them. Dry the irradiated area with patting motions rather than rubbing motions. Use a clean, soft towel or cloth. Use no powders, ointments, lotions, or creams on your skin at the radiation site unless they are prescribed by your radiologist or the radiation therapy advanced practice nurse. Wear soft clothing over the skin at the radiation site. Avoid wearing belts, buckles, straps, or any type of clothing that binds or rubs the skin at the radiation site. Avoid exposure of the irradiated area to the sun. Protect this area by wearing clothing over it, but not by applying sunscreen agents during the time you are undergoing the radiation treatments. Try to go outdoors. In the early morning or evening to avoid the more intense sun rays. When outdoors, stay under awnings, umbrellas, and other forms of shade during the times when the sun's rays are most intense, 10 a.m. to 7 p.m. Avoid heat exposure. NCLEX examination challenge. The client receiving radiation therapy to the chest for breast cancer asks if she can still play golf during the 6 weeks of her treatment. What is the nurse's best response? A. No, your risk for breaking a rib when swinging the golf club hard is greatly increased. B. No, you will be too tired to play golf until 2 months after the treatment is completed. Yes, if you wear a hat or wig to prevent damage to your scalp from sun or wind, or yes, if you wear a soft, thick shirt to protect your chest skin from sunlight. Chemotherapy. Overview. Chemotherapy, the treatment of cancer with chemical agents, has a major role in cancer therapy. Chemotherapy is used to cure and to increase survival time. It is used as cancer treatment because it has some selectivity for killing cancer cells over normal cells. This killing effect on cancer cells is related to the ability of chemotherapy to damage DNA and interfere with cell division. Thus, the tumors most sensitive to chemotherapy are those that have rapid growth. As described in Chapter 23, cancer cells can separate from the original tumor, spread to new areas, and establish new cancers at distant sites, or metastasize. Patients with metastatic cancer will die unless treatment eliminates the metastatic cancer cells along with the original cancer cells. Chemotherapy is useful in treating cancer because its effects are systemic, providing the opportunity to kill metastatic cancer cells that may have escaped local treatments. Chemotherapy used along with surgery or radiation is termed adjuvant therapy. Drugs used for chemotherapy usually are given systemically and exert their cell-damaging or cytotoxic effects against healthy cells as well as cancer cells. The normal cells most affected by chemotherapy are those that divide rapidly, including skin cells, hair, intestinal tissues, spermatocytes, and blood-forming cells. These drugs are classified by the specific types of action they exert in the cancer. Table 24.2 lists categories, drugs, and their potential to induce nausea and vomiting. Emetogenic, or vomiting would be emetogenic, or to damage surrounding tissues. Table 24.2 categories of chemotherapeutic drugs. So drug, the anti-metabolites, there's capecitabine or Xeloda. Its emetogenic potential is low, and tissue damage potential not applicable. It's oral. It's an oral drug. Okay, and then under anti-metabolites, there's cladribine or lustatin, and its emetogenic potential is moderate, and tissue damage potential is just bruising. And there's cytarabine or cytosar, and that's moderate, and has an irritant tissue damage potential. There's floxuridine or FUDR, and that has a high emetogenic potential and bruising for tissue. There's 5-fluorouracil, and that's also called Adrucil or Efudex, and that has a moderate potential and has an irritant effect. There's gemcitabine or Gemzar, and that's moderate and bruising. 6 mercaptoprine or probenethol, and that's low, and it's an oral drug, so it's no skin problems. Methotrexate or Mexate or Folex, That's low to moderate with bruising. And then there's 6, theoguanine or Lanvis, and that's moderate to high, and that's an oral drug. And there's anti-tumor antibiotics, and these would be bleomycin or blenozane, and that's a moderate with an irritant effect. Dactinomycin or cosmegin, and that has a high hematogenic potential, and it says vesicant for tissue. Donorubicin, and that's also called cerobidine, that's high with vesicant. And doxorubicin, that's adriamycin or Rubex, and that's high with vesicant. There's epirubicin, that's Elance, that's high with a vesicant. Idarubicin or idarubicin, and that's also called idomycin, and that's moderate to high with vesicant. Mitomycin C or mutamycin, that's moderate with vesicant. There's mitoxantrone or novantrone, and that's low with irritant. There's pentostatin or Nipent, and that's moderate to high with bruising. And then there's plicamycin or mithrasin, and that's high with irritant. And there's valrubicin, and that's not applicable on both of those. It's an intravesicular drug. And then there's the antimitotics, and that's docetaxel or Toxoteer, and that's moderate with bruising. Etoposide or VP16 or Vapecid, and that's low with irritant. Paclitaxel or Taxol, and that's moderate with irritant. Vinblastine or Velbin or Velbe or Velsar, and that's low moderate with vesicant. Vincristine or Oncovin, that's low with vesicant. Vinorelbine or Navalbine, that's low with vesicant. And there's the alkylating agents, and that's with that there's altratamine or Hexalin, and that's moderate, or it's an oral drug. Busulfan or Busulfex, that's high with bruising. Carboplatin or Paraplatin, that's high with irritant. Carmustine or BiCNU, that's high with an irritant effect. There's chlorambucil or Leukeran, that's high, and that's an oral drug. Cisplatin or Platinol, that's high with irritant effect. Cyclophosphamide or cytosine or Procytox, and that's high with bruising. There's estramustine or Emcyst or Estrocyte, and that's moderate with vesicant. There's ifosfamide or Ifex, and that's high with bruising. There's Lomustin, or CCNU or CNU, that's high with, and that's an oral drug. There's mechlorothamine or mustargin, that's high in vesicant. There's melphalan or Alkeran, that's high with, and it's an oral drug. Oxyplatin or Elozatin, high to moderate and vesicant. Streptozocin or Zanzozar, and that's high with bruising. Temozolomide or Temolidar, that's moderate to high, and it's an oral drug. Theotepa or Theoplex, that's low with bruising. And then there's topoisomerase inhibitors, and that's we have irinotecan or Camptazar, that's moderate, and it's an irritant. And topotecan or Hycamptin, that's high, or no, that's moderate with irritant. And then there's other agents, arsenic trioxide or Trisonex, that's moderate and not known.
asparaginase or Elspar, that's low and vesicant. There's dacarbazine or DTIC, that's moderate to high with an irritant. There's hydroxyurea or Hydrea, that's low and it's an oral drug. There's pegaspargase or Oncospar, and that's low with bruising. And procarbazine or matulane or natulan, and that's high and it's an oral drug. Okay, and all that made no sense, but whatever, I read it anyways. Chemotherapy, drug categories. There's antimetabolites. Antimetabolites are similar to normal metabolites needed for vital cell processes. Most cell reactions require metabolites in order to begin or continue the reaction. Antimetabolites closely resemble normal metabolites and are counterfeit metabolites that fool cancer cells into using the antimetabolites in cellular reactions. Because antimetabolites cannot function as proper metabolites, their presence impairs cell division. There's anti-tumor antibiotics. They damage the cell's DNA and interrupt DNA or ribonucleic acid RNA synthesis. Exactly how interruptions occur varies with each agent. Those are anti-tumor antibiotics. Then there's antimeiotic agents. These interfere with the formation of microtubules, so cells cannot complete mitosis during cell division. As a result, the cancer cell either does not divide at all or divides only once, resulting in two daughter cells that cannot continue to divide. There's alkylating agents. They cross-link DNA, making the two DNA strands bind tightly together. This tight binding prevents proper DNA and RNA synthesis, inhibiting cell division. There's topoisomerase inhibitors, and they disrupt an enzyme or topoisomerase needed for DNA synthesis and cell division. It nicks and straightens the DNA helix, allowing the DNA to be copied, and then reattaches the DNA together. These drugs prevent proper DNA maintenance, causing DNA breakage and cell death. Other miscellaneous chemotherapy drugs are those with mechanisms of action that are either unknown or do not fit those of the other drug categories. Drugs in this category are effective with some tumors. Combination chemotherapy. Successful cancer chemotherapy involves giving more than one specific anti-cancer drug in a timed manner. This technique is called a combination chemotherapy. Using more than one drug is much more effective in killing cancer cells than using only a single drug. However, the side effects and damage caused to normal tissue also increases with combination chemotherapy. Table 24.3 routes of chemotherapy administration. Oral. Typical cancers with oral would be Hodgkin's lymphoma, leukemia, maintenance phase, and small cell lung cancer. Intravenous would be most solid tumors in leukemias and lymphomas. Intraarterial would be hepatic tumors, primary and metastatic, and head and neck cancers for intraarterial. Isolated limb perfusion would be cancers confined to a limb, osteogenic sarcoma, Ewing's sarcoma, rhabdomyosarcoma, and regional melanoma. Intracavitary would be ovarian cancer. Also, intraperitoneal would be brain tumors. Intraventricular, also brain tumors. Intrathecal would be prophylaxis of acute lymphocytic leukemia. And intravesical or vesical would be bladder tumors. The selection of drugs is based on known tumor sensitivity to the drugs and the degree of side effects expected. For example, most chemotherapy drugs suppress bone marrow activity and immune function to some degree, but some agents cause more bone marrow suppression than others. There is also variation in the timing of drug-induced suppression and neutropenia. The time when bone marrow activity and white blood cell counts are at their lowest levels after chemotherapy is the nadir. It occurs at different times for different drugs. To reduce immunosuppression, combination chemotherapy avoids using drugs with nadirs that occur at or near the same time. A new approach of chemotherapy selection is checking the patient's genetic profile to determine the likelihood of experiencing dangerous side effects. This process, known as pharmacogenomics, allows a more individualized approach to chemotherapy selection. Treatment issues. Dosages for most chemotherapy drugs are calculated according to the type of cancer and the patient's size. Usually, calculations are based on milligrams per square meter of total body surface area, TBSA, which considers both the patient's height and weight. Chemotherapy drugs are given on a regular basis and are timed to maximize cancer cell kill and minimize damage to normal cells. The schedule may vary somewhat to accommodate a patient's response to therapy, but chemotherapy is usually scheduled every 3 to 4 weeks for a specified number of times, on average 4 to 12 times. Newer protocols are giving higher doses of chemotherapy more often, called dose-dense chemotherapy, are often used for aggressive cancer treatment, especially for breast cancer. This dose-dense chemotherapy also results in more intense side effects than traditional dosing schedules. Most chemotherapy drugs are given IV, although other routes may be used for specific cancers. Table 24.3 lists routes of chemotherapy administration. The techniques and care needs for different routes are described with the specific cancer types most commonly associated with a specific administration route. Chapter 15 describes the types of venous access devices, many of which are used for chemotherapy. The IV route is the most preferred route for chemotherapy because the effects of the drugs are rapid and because many of these agents are irritating or damaging to tissues. The standard of care designated by the Oncology Nursing Society, ONS, and supported by the American Society of Clinical Oncologists, ASCO, for safe administration of IV chemotherapy is that administration of these drugs requires special education. Special education for competency does not mean that only an advanced practice nurse can perform this function. However, it does mean that the person should be a registered nurse who has completed an approved chemotherapy course. Responsibility for monitoring the patient during chemotherapy administration, however, rests with all nurses providing care to that patient. A major complication of IV infusion is extravasation, or the movement of the IV needle so the drug leaks into the surrounding tissues, also called infiltration. When the drugs given are vesicants, or that meaning chemicals that damage tissue on direct contact, the results of extravasation can include infection and tissue loss. Surgical intervention is sometimes needed for severe tissue damage. See Table 24.2 for a listing of known vesicant and irritant chemotherapy drugs. The most important nursing intervention for extravasation is prevention. Small extravasations resolve without extensive treatment in less than 0.5 milliliters if less than 0.5 milliliters of the drug has leaked into the tissues. If a large amount has leaked, extensive tissue damage occurs and surgical intervention may be necessary. Thus, close monitoring of the access site is critical during chemotherapy administration to prevent leakage of large volumes. Immediate treatment depends on the specific drug. With some drugs, cold compresses to the area are prescribed. For other agents, warm compresses are used. Antidotes or chemoprotective agents may be injected into the site of extravasation. Coordinate with the oncologist and pharmacist to determine the specific antidote needed for the extravasated drug. Chart 24.3 outlines the best practices for documenting an extravasation event. Most chemotherapy drugs are absorbed through the skin and mucous membranes. As a result, the healthcare workers who prepare or give these drugs, especially nurses and pharmacists, are at risk for absorbing them, even at low doses. Long-term exposure to chemotherapy drugs can affect health. Anyone preparing, giving, or disposing of chemotherapy drugs or handling excreta from patients within 48 hours of receiving IV chemotherapy should use extreme caution and wear personal protective equipment. Such equipment includes eye protection, masks, double gloves or chemo gloves, and gown. The Occupational Safety and Health Administration, OSHA, and the ONS have established practice guidelines and protective standards. Side effects of chemotherapy. Actual temporary and permanent physical damage can occur to normal tissues from chemotherapy because this treatment is systemic and does not exert its effects only on cancer cells. Known problems include hemorrhagic cystitis, cardiac muscle damage, and loss of bone density. One approach to decrease the impact of chemotherapy on normal tissues is to give the agents with drugs that protect specific healthy cells. These drugs, called cytoprotectants, have little effect on cancer cells but do protect some normal tissues. Cytoprotective drugs used for chemoprotection. Amifostine or ethiol, or cytoprotective problem prevented or reduced would be xerostomia. Dexrazosane or Zinecard, that protects cardiomyopathy. Dexrazosane or Totec protects tissue damage from anthracycline extravasation. Mesna or Mesnex protects from hemorrhagic cystitis, and pamidronate or Aradia protects from skeletal complications. Chart 24.3, best practices for patients' safety and quality care. Documentation of extravasation. Document and date and time when extravasation was suspected or identified. Document the date and time when the infusion was started. Record the time when the infusion was stopped. Document the exact contents of the infusion fluid and the volume of fluid infused. Document the estimated amount of fluid extravasated. Diagram the exact insertion site and indicate whether this is a venous access device, an implanted port, or a tunneled catheter. Document the method of administration, pump, controller, etc., rate of infusion. Document the needle type and size. Indicate on the diagram the location and number of venipuncture attempts. Record the time between the extravasation and the last documented full blood return. Identify all agents administered in the previous 24 hours through this site. List agent administered, dosage and volume in order of administration. Take and record the patient's vital signs. Ask and record the patient's subjective sensations and symptoms. Record all observations of the site, including size, color, and texture. Take a photograph of the site. Document the administration of neutralizing or antidote agents. Document the application of compresses and their temperature. Document other nursing interventions. Record the patient's response to nursing interventions. Document the prescribing physician's notification, including the time. Document the written and oral instructions given to the patient about follow-up care. Document any consultation requests. Sign the documentation. Back to the text. Serious short-term side effects occur with aggressive chemotherapy. The side effects on the hematopoietic or blood-producing system can be life-threatening and are the most common reason for changing the dosage or schedule. The suppressive effects on the blood-forming cells of bone marrow cause anemia, decreased numbers of red blood cells, and hemoglobin. Neutropenia, decreased numbers of white blood cells, leading to immunosuppression, and thrombocytopenia, decreased number of platelets. Less life-threatening but common distressing side effects include nausea and vomiting, alopecia or hair loss, mucositis, open sores on mucous membrane, and many skin changes. Other distressing side effects include anxiety, sleep disturbance, altered bowel elimination, and changes in cognitive function. These side effects are referred to as cancer therapy symptom distress. Drug therapy often is used to reduce symptom distress.
for some of these side effects. For other problems, such as alopecia, the side effect cannot be prevented, but the patient can be helped to reduce his or her distress from its presence. General non-pharmacologic nursing interventions for many types of symptom distress include distraction, massage, guided imagery, Reiki, aromatherapy, and other forms of complementary therapy. In addition to physical side effects of therapy, psychosocial issues can occur even during chemotherapy administration. For many chemotherapy regimens, drugs are given over a period ranging from 2 hours to as long as 8 hours. During this time, the patient is confined to a treatment area and is constantly reminded of his or her disease and treatment. Most patients view this time as unpleasant. Distraction methods such as guided imagery, reading, watching television, and talking with visitors have minimal effect on reducing the sense of unpleasantness. A new distraction method, the use of virtual reality during chemotherapy administration, has been shown to help reduce the patient's awareness of the chemotherapy environment and alter the sensations of unpleasantness. See the evidence-based box, page 425. Distraction alone, however, does not reduce the symptom distress experience during the and after chemotherapy. Patient-centered collaborative care. The priority care issues during chemotherapy are protecting the patient from the life-threatening side effects and managing the distressing symptoms that occur with therapy. For some patients, the symptoms are so unpleasant that they stop treatment. Bone marrow suppression. In addition to killing cancer cells, chemotherapy also destroys some circulating blood cells and reduces replacement of these cells by suppressing bone marrow function. The numbers of all circulating leukocytes, erythrocytes, and platelets are decreased. Reduced leukocyte numbers, especially reduced neutrophils, neutropenia, greatly increase the risk of infection. Decreased erythrocytes and platelets cause hypoxia, fatigue, and an increased tendency to bleed. Evidence-based practice. Distraction. It's not just for kids anymore. Okay. Virtual reality. A distraction intervention for chemotherapy. I can't wait to read this. Okay. Receiving IV chemotherapy for cancer, taking anywhere from 1 to 8 hours, is often described by patients as an extremely unpleasant experience. Patients are usually required to stay within a confined area during the treatment because of the tissue-damaging nature of the drugs and the possibility of extravasation or infiltration with movement. Thus, patients are in a setting that constantly reminds them of the disease and treatment with little diversion available to occupy or distract them. Children have been able to derive positive distraction during the chemotherapy experience through the use of virtual reality or VR. This distraction intervention has not been studied for its effectiveness in adult cancer patients undergoing chemotherapy. The current study sought to determine the usefulness of VR as a distraction in reducing the unpleasant nature of cancer, chemotherapy, and reducing symptom distress among adults. The study used a randomized crossover design with 123 patients, adult patients, being treated for breast, colon, and lung cancer. Patients either were assigned to use virtual reality during the first round of chemotherapy, followed by chemotherapy treatment rounds without the intervention, or received one or more rounds of chemotherapy with no VR, followed by a round of chemotherapy with VR. 100 patients completed all aspects of the study. At the end of the chemotherapy sessions with and without VR, subjects completed well-established and reliable instruments measuring symptom distress, state, anxiety, and fatigue, as well as an evaluation of VR intervention and questionnaire. These instruments were administered again at 48 hours after the chemotherapy sessions. When using VR, subjects perceived the length of the chemotherapy session to be nearly 25% shorter than it actually was. No person had any adverse effects from the VR, and most stated that it did make the chemotherapy experience more pleasant. 82% said they would like to use VR during chemotherapy again, although symptoms distress declined slightly after use of VR compared with the chemotherapy sessions without VR. This difference did not reach statistical significance. Level of evidence. 4. The study was a well-designed cohort study. Commentary. Implications for practice and research. The use of VR to make the chemotherapy experience more pleasant appears to be a positive distraction without adverse effects. Although some patients can distract themselves by reading, employing guided imagery, and other self-immersion methods,
VR may be of greatest benefit to those people who are not as adept at self-immersion. Methods of reducing the unpleasant sensations associated with chemotherapy may help improve treatment outcomes by encouraging patients to continue therapy. Although the initial expense of VR equipment is significant, it may be worth the cost to help make chemotherapy treatments more tolerable. VR is an additional non-pharmacological intervention nurses can implement when caring for patients receiving cancer therapy. Nurses can advocate with their agency to ensure this intervention is an option for their patients. Yeah, whatever. Okay, back to the text. Infection risks result from neutropenia, placing the patient at extreme risk for sepsis. This critical problem is the major dose-limiting side effect of cancer chemotherapy and a common cause of death for patients during treatment. Most chemotherapy drugs suppress bone marrow function to some degree and decrease the patient's protective responses to organism invasion. The severity and duration of the impairment are related directly to the dosage of specific chemotherapeutic drugs. This impairment is temporary, with good recovery of protection within weeks after therapy completion. However, the seriousness of potential infection complications makes this problem a major treatment concern. The infection processes that occur most commonly are fungal, bacterial, and some residual viral breakdown. Most of the infections that develop in a patient with neutropenia result from overgrowth of the patient's own normal flora. Infection risks can be managed with the use of biological response modifiers, or BRMs, to stimulate bone marrow production of immune system cells. Although not appropriate for all types of cancer, this supportive treatment can reduce the risk for infection during chemotherapy. However, BRMs are expensive and not consistently covered by insurance. Of course not. This treatment is discussed on page 433 and 434 in the immunotherapy section. Actual infections are treated with anti-infective drugs such as antibiotic, antifungal, and antiviral drugs. Just like for any other infection, anti-infective therapy is specific for the organisms causing the infection. Complementary and alternative therapies. Many patients with cancer using complementary and alternative therapies to boost immune function and prevent infection. Or many people with cancers use complementary and alternative therapies to boost immune function and prevent infection. Common therapies include shark cartilage, echinacea, and megadoses of vitamin C. Although benefit has not yet been determined in clinical trials, the use of these therapies does not appear to have harmful effects. The priority nursing interventions for the patient with neutropenia are protecting him or her from infection within the healthcare system and teaching the patient and family how to reduce infection in the home. Total patient assessment, including skin and mucous membrane inspection, lung sounds, mouth assessment, and close inspection of venous access device insertion sites, should be performed every 8 hours by a registered nurse. Explain to the patient that the importance of reporting any changes in the skin and mucous membrane or other health status. Instruct him or her to report any pimple, sore, skin rash, or open area. Other changes to teach him or her to report are the presence of a cough, burning on urination, pain around the venous access site, or new drainage from any location. Good hand washing before contact with the patient is essential for prevention of infection. Healthcare workers must use a septic technique when performing any invasive procedure. Chart 24.4 lists the best practices for infection protection with neutropenia patients. When delegating any nursing care activity to unlicensed assisted personnel with supervision, teach them the importance of protecting the neutropenic patient from infection. Stress the ways that cross-contamination can occur and how to avoid this source of infection. Also ensure that unlicensed assisted personnel understand that even when the neutropenic patient is very tired and does not feel well, certain aspects of personal hygiene cannot be deferred. Teach the importance of mouth care and washing of the axillary and perianal regions at least every 12 hours. Monitoring for manifestations of infection is critical for the hospitalized patient with neutropenia. The reduced number of neutrophils and other white blood cells can limit the presence of common infection manifestations. Often the patient with neutropenia does not develop a high fever or a purulent drainage even when a severe infection is present. Any elevation of temperature in a patient with neutropenia is significant and is considered a sign of infection and should be reported to the healthcare provider immediately. Hospital units specializing in care for neutropenic patients often have protocols or standards orders that nurses initiate as soon as an infection is suspected, before a physician examines the patient, because treatment delay can result in sepsis and death. These protocols usually specify what types of cultures to obtain, e.g. blood, urine, sputum, central line, or wound, what diagnostic tests to obtain, e.g. chest x-ray, and what antibiotics to immediately start. Many patients remain at home during periods of neutropenia and are at continuing risk for infection. Even though most home environments are likely to have fewer pathogenic organisms, the focus remains on keeping the patient's own normal flora under control and preventing transmission of organisms from other people to him or her. At no time is the patient an infection hazard to other people. However, other people can be infection hazard to the patient. Teach patient and family member precautions to reduce the risk for infection. Anemia, or decreased number of circulating blood cells, and thrombocytopenia, reduced circulating platelets, also result from the bone marrow suppression caused by some chemotherapy drugs. Anemia causes patients to feel fatigued, and some tissues are hypoxic. The cardiac and respiratory systems may not be able to maintain adequate oxygenation. Thrombocytopenia increases the risk for excessive bleeding. When the platelet count is less than 50,000, any small trauma can lead to prolonged bleeding. Patients with fewer than 20,000 platelets per mm3 have spontaneous, and that's millimeters cubed, I guess, have this spontaneous and uncontrollable bleeding requiring transfusion therapy. The use of biological response modifiers, or BRMs, to stimulate bone marrow production of red blood cells and platelets is common for some types of cancer. Erythropoiesis stimulating agents, or ESAs, such as darbepoetin alpha or aranesp, and epoetin alpha or epigen or procrit, can prevent or improve anemia associated with chemotherapy and can reduce the need for transfusion therapy. These drugs, however, do increase the production of many cells types, not just erythrocytes, increasing the patient's risk for hypertension, blood clots, strokes, and heart attacks, especially among older adults. In addition, certain types of cancer cells grow faster in the presence of these ESAs, such as head and neck cancer cells, leukemias, and some lymphomas. The basis of dosing for these drugs is now the monitoring of individual patient hemoglobin levels to ensure that just enough red blood cells are produced to avoid the need for transfusion, but not to bring hemoglobin or hematocrit levels up to normal. BRM therapy for thrombocytopenia is the use of oprelvecin, or Numega. This modified version of interleukin 11, or IL-11, increases the production of platelets. The drug causes fluid retention and increases the risk for congestive heart failure and pulmonary edema. Other side effects include conjunctiva bleeding, hypotension, and tachycardia. Teach patients taking this drug to weigh themselves daily and keep a record of their weight. Dyspnea should be reported immediately to the healthcare provider. Patient 24-5, Patient and Family Education Guide. Prevention of infection. During the times your white blood cell counts are low, you want to avoid crowds and other large gatherings of people who might be ill. Do not share personal toilet articles such as toothbrushes, toothpaste, washcloths, or deodorant sticks with others. If possible, bathe daily using an antimicrobial soap. If total bathing is not possible, wash the armpits, groin, genitals, and anal area twice a day with an antimicrobial soap. Clean your toothbrush daily by either running it through the dishwasher or rinsing it in liquid laundry bleach. Wash your hands thoroughly with an antimicrobial soap before you eat and drink, after touching a pet, after shaking hands with anyone, as soon as you come home from any outing, and after using the toilet. Eat a low bacteria diet and avoid salads, raw fruit and vegetables, undercooked meat, fish or eggs, and pepper and paprika. Wash dishes between use with hot, sudsy water or use a dishwasher. Do not drink water, milk, juice, or other cold liquids that have been standing at room temperature for longer than an hour. Do not reuse cups and glasses without washing. Do not change pet litter boxes. Take your temperature at least once a day and whenever you do not feel well. Report any of these signs or symptoms of infection to your physician immediately. Temperature greater than 100, persistent cough with or without sputum, pus or foul-smelling drainage from an open skin area or normal body opening, presence of a boil or abscess, urine that is cloudy or foul-smelling or that causes burning or on urination. Take all prescribed drugs. Do not dig in the garden or work with houseplants. And wear a condom if you're a man when having sex. If you're a woman having sex with a male partner, ensure that he wears a condom. Okay. Chart 24-4. Best practice for patient safety and quality care. Care of patient with neutropenia. Place the patient in a private room whenever possible. Use good hand washing technique. One second. Okay, one more time. Care of patient with neutropenia. Place the patient in a private room whenever possible. Use good hand washing technique or use alcohol-based hand rubs before touching the patient or any of the patient's belongings. Ensure that the patient's room and bedroom are cleaned at least once a day. Do not use supplies from common areas for neutropenic patients. For example, keep a sleeve or a box of paper cups in the patient's room and do not share this box with any other patient. Other articles including drinking straws, plastic knives and forks, dressing materials, gloves, and bandages. Limit the number of healthcare personnel entering the patient's room. Monitor vital signs every 4 hours, including temperature. Inspect the patient's mouth at least every 8 hours. Inspect the patient's skin and mucous membranes, especially the anal area, for the presence of fissures and abscesses at least every 8 hours. Inspect open areas such as IV sites every 4 hours for manifestations of infection. Change wound dressings daily. Obtain specimens of all suspicious areas for culture, as specified by the agency, and promptly notify the physician. Assist the patient in coughing and deep breathing exercises. Encourage activity at a level appropriate for the patient's current health status. Change IV tubing. Keep frequently used equipment in the room for use with this patient only, e.g. blood pressure cuff, stethoscope, thermometer. Limit visitors to healthy adults. Use strict aseptic technique for all invasive procedures. Monitor the white blood cell count, especially the absolute neutrophil count, also called the ANC, daily. Avoid the use of indwelling urinary catheters. Keep fresh flowers and potted plants out of the patient's room. Teach the patient to eat a low-bacteria diet, e.g. avoiding raw fruits or vegetables, undercooked meat, eggs or fish, pepper and paprika as seasonings sprinkled on food right before eating. Okay, the priority for nursing care for the patient with thrombocytopenia is to provide a safe hospital environment. Chart 24.6 lists the best practices for bleeding precautions during hospitalization. Be sure that unlicensed assistive personnel understand the importance of using bleeding precautions and the need to report any evidence of bleeding immediately. Teach patients with thrombocytopenia and their families how to avoid injury and excessive bleeding when patients are discharged before the platelet count has returned to normal. Chart 24/7 reviews what specifically to teach patients for how to prevent bleeding and what to do if bleeding occurs. Chemotherapy-induced nausea and vomiting, or CIN. Nausea and vomiting arise from a variety of local and central nervous system mechanisms. Most chemotherapy drugs are emetogenic, or vomiting-inducing, to some degree, depending on the dose. Most drugs induce nausea and vomiting when the drug is given and for 1 to 2 days afterward. Some drugs, such as cisplatin, induce delayed nausea and vomiting that can continue as long as 5 to 7 days after receiving it. Patients who have chemotherapy-related nausea and vomiting during one round of chemotherapy may begin to have the same symptoms before the next round as a result of sheer anticipation. Once considered the single most distressing side effect of chemotherapy, CIN often can be well controlled with appropriate therapy. Many medics are available to relieve nausea and vomiting. These drugs vary in the side effects they produce and how well they control chemotherapy-induced nausea and vomiting. One or more antiemetics are usually given before and after chemotherapy. Drugs commonly used short-term to control chemotherapy-induced nausea and vomiting are listed in Chart 24.8. Patient response to antiemetic therapy is highly variable, and the drug combination should be individualized for best effect. Chapter 24/7. Patient and Family Education Guide, Preventing Injury or Bleeding. During the time your platelet count is low, During the time that your platelet count is low, use an electric shaver, use a soft bristle toothbrush, and do not floss. Do not have dental work performed without consulting your cancer health care provider. Do not take aspirin or any aspirin-containing products. Read the label to be sure that the product does not contain aspirin or salicylates. Do not participate in contact sports or any activity likely to result in your being bumped, scratched, or scraped. If you are bumped, apply ice to the site for at least 1 hour. Avoid hard foods that would scrape the inside of your mouth. Eat warm, cool, or cold foods to avoid burning your mouth. Check your skin and mouth daily for bruises, swelling, or areas with small reddish-purple marks that may indicate bleeding. Notify your cancer health care provider if you are injured and persistent bleeding results, have excessive menstrual bleeding, see blood in your bowel movement. Avoid anal intercourse. Really? Just kidding. Take a stool softener to prevent straining during a bowel movement. Do not use enemas or rectal suppositories. Avoid bending over at the waist. Do not wear clothing or shoes that are tight or that rub. Avoid blowing your nose or placing objects in your nose. If you must blow your nose, do so gently without blocking either nasal passage. Avoid playing musical instruments that raise the pressure inside your head, such as brass, wind instruments, and woodwinds or reed instruments. Chart 24/6. Best practice for patient quality care. Prevention of injury for the patient with thrombocytopenia. Handle the patient gently. Use and teach UAP or unlicensed assisted personnel to use a lift sheet when moving and positioning the patient in bed. Avoid IM injections and venipunctures. When injections or venipunctures are necessary, use the smallest gauge needle for the task. Apply firm pressure to the needle stick site for 10 minutes or until the site no longer oozes blood. Apply ice to areas of trauma. Test all urine and stool for the presence of occult blood. Observe IV sites every 4 hours for bleeding. Instruct alert patients to notify nursing personnel immediately if any trauma occurs and if bleeding or bruising is noticed. Avoid trauma to rectal tissues. Instruct UAP not to take temperatures rectally, even on unconscious patients. Do not administer enemas. If suppositories are prescribed, lubricate liberally and administer with caution. Measure the patient's abdominal girth daily. Instruct the patient and UAP to use an electric shaver rather than a razor. When providing mouth care or supervising others in providing mouth care, use a soft bristle toothbrush or tooth sponges. Do not use floss. Do not use water pressure gum cleaners. Make certain that dentures fit and do not rub. Instruct the patient not to blow the nose or insert objects into the nose. Instruct UAP and the patient to wear shoes with firm soles whenever ambulating. Keep patient pathways and hallways clear and uncluttered. Regardless of which drug or drugs are being used to prevent or reduce CIN, they are most effective, and we're talking back into the text and talking about chemotherapy-induced nausea. Regardless of which drug or drugs are being used to prevent or reduce CIN, they are most effective when used aggressively and on scheduled basis. Just like pain management, drug therapy works best when given before pain intensity increases, so does drug therapy for CIN. Thus, the nursing priority is to coordinate with the patient and healthcare provider to ensure adequate control of CIN. Ensure the pre-medication and with antiemetics is given before each session of IV chemotherapy. When patients are receiving dose-dense chemotherapy, the intensity of CIN also increases, and more or longer antiemetic therapy is needed. Teach patients to continue the therapy as prescribed, even when the nausea and vomiting appear controlled. When the patient stops taking the drugs, he or she should start retaking the drug at the first sign of nausea to prevent this side effect from becoming uncontrollable. Considerations for older adults. At times, older patients have received lower doses of chemotherapy drugs because it was thought that they would not be able to tolerate the side effects of nausea and vomiting. Research indicates that older patients do not have greater nausea and vomiting than do younger patients. Therefore, their chemotherapy regimens should not be altered on this basis alone. However, the older adult can become dehydrated more quickly if CNN is not adequately controlled. Teach older patients to be proactive with taking their prescribed antiemetics and to contact their healthcare provider if the CIN either does not resolve within 12 hours or becomes worse. Complementary and alternative therapies. Complementary and alternative therapies may assist the patient with nausea and vomiting to achieve comfort through non-pharmacologic means with the antiemetics. Progressive muscle relaxation, guided imagery, acupressure, or distraction may help reduce anxiety and relieve nausea and vomiting. Assess the patient for complications resulting from excessive vomiting, such as dehydration and electrolyte imbalances. Mucositis. Mucositis, sores in mucous membrane, often develops in the entire GI tract, especially in the mouth, or called stomatitis. Normally, the lining of the GI tract undergoes rapid cell division and quickly replaces cells. With chemotherapy, mucous membrane cells are killed more rapidly than they are replaced, resulting in sore formation. Mouth sores are painful and interfere with eating and general quality of life. Chart 24.9 lists the best practices for patients with mucositis. Frequent mouth assessment and oral hygiene are key in managing stomatitis and mucositis. Stress the importance of good and frequent oral hygiene, including teeth cleansing and mouth rinsing. Because most patients with mucositis also have bone marrow suppression and are at risk for bleeding, they must take care to avoid traumatizing the oral mucosa. Instruct them to use a soft bristled toothbrush or disposable mouth sponges and to avoid using dental floss and water pressure gum cleaners. Encourage them to rinse the mouth with plain water or saline every hour while awake. Teach them to avoid mouthwashes that contain alcohol or other drying agents that may further irritate the mucosa. Oral hygiene equipment must be kept clean. Remind patients not to share toothbrushes with anyone. Toothbrushes can be cleaned daily by running them through a home dishwasher or by rinsing them with a concentrated solution of liquid bleach or hydrogen peroxide. Many compounds are available for pain relief from stomatitis or mucositis. Many hospitals offer their own special swish and spit mixtures, which contain a local anesthetic combined with anti-inflammatory agents. Tell the patient that these mixtures are not to be swallowed. Alopecia. Alopecia, or hair loss, may occur as whole body hair loss or may be as mild as only a thinning of the scalp hair. Reassure patients that hair loss is temporary. Hair regrowth usually begins about 1 month after completion of chemotherapy. Inform the patient that the new hair may differ from the original hair in color, texture, and thickness. No known treatment completely prevents alopecia. The priority nursing interventions for the patient with chemotherapy-induced alopecia are to teach the patient to prevent injury to the scalp and to assist the patient in coping with this body image change. Chart 24A, common examples of drug therapy. Antiemetic drugs for chemotherapy-induced nausea and vomiting. So the drug would be dosage start out with serotonin antagonists. It would be ondansetron or Zofran, 8 milligrams IV or orally every 8 hours. This prevents chemotherapy-induced nausea by blocking the 5-HT3 receptors in the brain, trigger zone, and in the intestines. This action prevents serotonin from binding to the receptors and activating the nausea and vomiting centers. And that goes for all of the serotonin ones, which are also Kytril, 1 milligram, or granisetron, dolacitron, or Anzimet, and palonosetron, or Aloxi. Nursing interventions with the SS, or they're serotonin antagonists, so they're SSRIs or SRNRIs. Teach patient to change positions slowly to avoid falls. Assess the patient for headaches. Rationale: these drugs may induce bradycardia, hypertension, and vertigo. Headache is a common side effect of drugs from this class. And then there's a med alert on those. Do not confuse Anzimet with Avandamet. Don't do that. And there's neurokinin receptor antagonists, and that's apretant. Day 1, 125 milligrams. Day 2 and 3, 80 in the morning. No chemo these days. Action: they reduce chemotherapy-induced nausea by blocking the substance P, neurokinin receptor, when used together with serotonin antagonists and a corticoid or corticosteroid. Both acute and delayed nausea and vomiting are controlled. I'm going to teach patients who are also taking warfarin or Coumadin to have their INRs checked before and after the 3 days of this therapy. Teach women who are using oral contraceptives to use an additional form of birth control while on this drug. This drug interferes with the effectiveness of warfarin. The drug reduces the effectiveness of oral contraceptives, increasing the risk for unplanned pregnancy. And then there's corticosteroids, dexamethasone or Decadrone, 5-10 milligrams IV or orally daily. Reduces CIN by decreasing swelling in the brain's chemotrigger zone. Teach patients to reduce salt intake to about 4 grams a day. Drug causes fluid retention and hypertension. Prokinetic agents, metoclopramide or Reglan,
20 to 40 milligrams. Reduces CIN by blocking dopamine receptors in the brain's chemotrigger zone. Teach the patient to avoid driving or operating heavy machinery. Increased drowsiness is common. And then benzodiazepines, lorazepam, Ativan, 1 to 3 milligrams orally or IV twice or 3 times daily. Reduce CIN by enhancing cholinergic effects and by decreasing the person's awareness. Teach the patient family that patients should avoid driving, operating heavy machinery, making legal decisions, and going up and down staircases unassisted. Drug induces amnesia and profound drowsiness. Now on to chart 24.9. Best practices for patient safety and quality care. Mouth care for patients with mucositis. Examine the patient's mouth, including the roof, under the tongue, and between the teeth and cheek every 4 hours. Document the location, size, and character of fissures, blisters, sores, or drainage. Get in order to obtain specimens or sores or drainage for culture. Brush the teeth and tongue with a soft bristled brush or sponges every 8 hours. Rinse the mouth with a solution of 1/2 peroxide and 1/2 normal saline every 12 hours. Avoid the use of alcohol or glycerin-based mouthwashes. No Listerine, I don't think. Encourage the patient to drink 3 or more liters of water per day if another health problem does not require limiting fluid intake. Administer antimicrobial drugs as prescribed. Administer topical analgesia drugs as prescribed or as needed. Help the conscious patient to swish and spit room temperature tap water or normal saline as needed. Apply petroleum jelly to the patient's lips after each episode of mouth care and as needed. Assist the patient in using artificial saliva as needed if prescribed. Urge the patient to avoid using tobacco or drinking alcoholic beverages. Assist the patient in menu choices to avoid spicy, salty, acidic, dry, rough, or hard food. Cool liquids to prevent burns or irritation. If the patient wears dentures, encourage him or her to use them only during meals. When not in place, soak dentures in an antimicrobial solution. Rinse thoroughly before placing the dentures in the patient's mouth. Offer complete mouth care before and after every meal. Back to the text, still talking about alopecia. The hairless scalp is at risk for injury. Teach the patient to avoid direct sunlight on the scalp by wearing hats or other head coverings. Sunscreen use is essential to prevent sunburn, even with minimal sun exposure. Many chemotherapy drugs increase sun sensitivity, regardless of skin darkness. This skin can be damaged by helmets, headphones, headsets, and other items that rub the head. Teach the patient to wear some head covering underneath these items. In addition, head coverings during cold weather are needed to reduce body heat loss and prevent hypothermia. Assist patients in selecting a type of head covering that suits their income and lifestyle. One recommendation is to coordinate wig purchases with the patient's hairdresser or barber. Having very short hair or a shaved head now is common and socially acceptable for men, and many men choose not to wear a wig during chemotherapy. Cutting the hair very short or even shaving the head before chemotherapy begins allows a better wig fit. This practice also removes the uncertainty for when the hair loss will occur. Suggests that women purchase a wig before therapy begins and have their hairdresser shape the wig to mimic their usual hairstyle so there's less change in appearance. If possible, having 2 wigs is good so that one can always be clean and ready to wear. High-quality wigs are expensive but can look very much like the patient's own hair. Many local units of the American Cancer Society offer the loan of wigs that other patients have used and then donated to be lent to others with cancer. Patients can disguise their hair loss with caps, scarves, and turbans. Some support groups such as the American Cancer Society Look Good, Feel Better program can offer suggestions to help patients improve their appearance at this time. I like bald chicks, but whatever.
Changes in cognitive function. Some patients being treated with chemotherapy have reported changes in cognitive function, most commonly reduced ability to concentrate, memory loss, and difficulty learning new information during treatment, and for months to years after treatment. Although most types of chemotherapy drugs do not cross the blood-brain barrier and were thought not to affect any part of brain function, the drugs can induce general biochemistry changes that could reduce cognitive function, at least temporarily. This problem, termed chemobrain by patients, has been reported most in women who have had chemotherapy for breast cancer. Changes in cognitive function are not limited either to women or to breast cancer treatment. The fact that it is reported more in this population reflects the issues that breast cancer is very common. It is often treated with dose chemotherapy, and most patients with breast cancer survive a long time after therapy. Recent studies have compared brain structure and cognitive function among groups of women with breast cancer who did not receive chemotherapy, groups of women with breast cancer who did receive chemotherapy, and groups of healthy women. One study found that women receiving chemotherapy, especially with platinum-based drugs, had some shrinkage of both the white matter and the gray matter of the brain, determined by MRI, during chemotherapy, and at 1 year after chemotherapy was completed, compared with no shrinkage in control subjects. At 3 years after completion of therapy, no difference in brain volumes were found between the chemotherapy and control groups. 2 other studies examined cognitive functions and discovered that about 25% of women having chemotherapy experienced decreased cognitive function during and after therapy completion, compared with only about 5% of women who did not receive chemotherapy. One puzzling feature of this problem is that only some of the women receiving specific chemotherapy for breast cancer experienced a noticeable reduction in cognitive function. At present, not only is the exact cause of this side effect unclear, so are the personal risk factors. The priority for nursing care is to support the patient who reports this side effect, listen to the patient's concerns, and tell him or her that other patients have also reported such problems. Providing absolute reassurance is difficult because only a few studies using appropriate research methods have examined this issue. However, early results indicate that recovery is likely with time. A common sense approach includes that patients should be warned against also participating in other behaviors that could alter cognitive functioning, such as excessive alcohol intake, recreational drug use, and activities that increase the risk for head injury. Peripheral neuropathy. Peripheral neuropathy, PN, is the loss of sensory or motor function of peripheral nerves. Although most commonly seen in patients with long-term diabetes, patients undergoing chemotherapy with nerve-damaging drugs, especially the antimitotics and platinum-based drugs, often have rapid onset of severe PN. The degree of PN is related to the dosage of the nerve-damaging drugs. Higher doses lead to greater neuropathy. This side effect is not new. However, it is more common now as long-term cancer survival has increased. The results of PN on function are widespread, with the most common problems including loss of sensation in the hands and feet, orthostatic hypotension, erectile dysfunction, neuropathic pain, loss of taste discrimination, and severe constipation. PN appears to be a long-term consequence and may be permanent in some people, although this is not yet known. At present, no known interventions prevent PN. Okay. Okay, the priority for nursing care of patients experiencing PN is teaching the patient to prevent injury. Loss of sensation increases the patient's risk for injury because he or she may not be aware of excessive heat, cold, or pressure, just like for patients with diabetes. The risk for injury to the feet is very high. In addition, falls are more likely because the patient cannot feel changes in terrain and because of orthostatic hypotension. Chart 2410 lists teaching priorities for the patient with chemotherapy-induced peripheral neuropathy. Some issues, such as erectile dysfunction, may be helped with special devices or drug therapy. See Chapter 75 for more complete discussion of options for erectile dysfunction. Other issues are not correctable and often affect many aspects of quality of life. For example, the loss of sensation in the hands may make some occupations and leisure activities that requires very fine motor skills impossible. For other, such as piano playing, the person may have to watch his or her hands to know just where the keys are, and may not be able to control how hard a key is struck. Assess the patient's ability to cope with these changes. Coordinate with an occupational therapist to assist the patient in finding ways to adjust for sensory deficits in performing desired activities or in finding alternative activities. Chart 2410, Patient and Family Education Guide, Chemotherapy-Induced Peripheral Neuropathy. Protect feet and other body areas where sensation is reduced, e.g. do not walk around in bare feet or stocking feet. Always wear shoes with protective sole. Be sure shoes are long enough and wide enough to prevent creating sores or blisters. Provide a long break-in period for new shoes. Do not wear new shoes for longer than 2 hours at a time. Excuse me. Avoid pointed toe shoes and shoes with heels higher than 2 inches. Inspect your feet daily with a mirror for open areas or redness. Avoid extremes of temperature. Wear warm clothing in the winter, especially over hands, feet, and ears. Test water temperatures with a thermometer when washing dishes or bathing. Use warm water rather than hot water, less than 110 degrees Fahrenheit. Use pot holders when cooking. Use gloves when washing dishes or gardening. Do not eat foods that are steaming hot. Allow them to cool before placing them in your mouth. Eat foods that are high in fiber, e.g. whole grain, cereals, vegetables. Okay, drink 2 or 3 liters of fluid, non-alcoholic, daily, unless your a healthcare provider has told you to restrict fluid intake. Get up from a lying or sitting position slowly. If you feel dizzy, sit back down until the dizziness fades. Before standing, then stand in place for a few seconds before walking or using the stairs. Look at your feet and the floor or ground where you are walking to assess how the ground, floor, or step changes to prevent tripping or falling. Avoid using area rugs, especially those that slide easily. Use handrails when going up or down steps. NCLEX Examination Challenge. The client is receiving IV chemotherapy over 8 hours on the med-surg unit. The drugs started by a chemotherapy certified nurse are being monitored by the unit nurses. After 2 hours, the client reports burning and pain at the IV site. Lowering the IV results in an observable brisk blood return. What is the nurse's best first action? A. Stop the drug infusion and run normal saline into IV access. B. Notify the chemotherapy certified nurse who started the infusion. C. Slow the infusion but continue it since there is a good blood return. D. Discontinue the infusion, remove the IV, and document the site condition. I'm not sure. Hormonal manipulation. Overview. Hormones are naturally occurring chemicals secreted by endocrine or ductless glands, or ductless glands, and picked up by capillaries. Once In the bloodstream, hormones circulate to all body areas but exert their effects only on their specific target tissues. Some hormones make hormone-sensitive tumors grow more rapidly, and some tumors require specific hormones to divide. Thus, decreasing the amount of these hormones to hormone-sensitive tumors can slow the cancer growth rate. Hormonal manipulation can help control some types of cancer for many years. Usually this therapy does not lead to a cure. The endocrine system usually maintains a delicate hormone balance. When a large amount of one hormone is given, it upsets the balance and disturbs the uptake of other hormones. If a tumor depends on hormone A for growth and a large quantity of hormone B, similar to A, is given to the patient, hormone B will interfere with the tumor's uptake of hormone A or will limit the amount of hormone A produced. As a result, tumor growth is slowed and survival time increases. Table 24.5 lists the drugs commonly used in hormonal manipulation for cancer therapy. Speak of the devil, table 24.5, common agents used for hormonal manipulation of cancer. Type of agent, hormone agonists. You would have androgen. Examples of androgen are fluoxymesterone or halostestin, testolactone or Teslac, and chlorotrianisine or TACE. That's androgen. Estrogen. You could have conjunctive equine estrogen, Premarin, dithylstilbestrone or DES, stilfostrol. There's ethinyl estradiol. That's Estenel, and medroxy. Oh wait, no, this is the next one. And there's progestin. That's medroxyprogesterone or Amen or Provera, and megestrol or Megace. Also, luteinizing hormone releasing hormone LHRH. That's Leuprolide or Eligard or Lupron or Viadur, and Goserelin or Zoladex. And there's hormone antagonists. There's anti-androgens, which would be bicalutamide or Casodex, and flutamide or Ulexin. Also fulvestrant or Faslodex. And then there's anti-estrogens. That would be tamoxifen or Nolvadex, and toramifene or Ferristone. And there's hormone inhibitors, and those are aminoglutathione, cytodren elliptin. There's anastrozole or Arimidex. There's exemestane or Aramacin, and letrozole or Femara. Some drugs are hormone antagonists that compete with natural hormones. Some drugs are hormone antagonists that compete with natural hormones at the receptor sites. Often they are antibodies specific to the receptor. When hormone antagonists are given, they bind to the specific hormone receptor on or in the tumor cell and prevent the needed hormone from binding to the receptor. If the tumor needs a certain hormone to grow, and the hormone can enter or activate the cell only through a receptor, hormone antagonists can slow down tumor growth. A new class of drugs used for hormonal therapy is the hormone inhibitors. These drugs inhibit the production of specific hormones in the normal hormone-producing organs. For example, the aromatase inhibitor, or anastrozole or arimidex, prevents the production of estrogen in the adrenal gland and reduces blood levels of estrogens. Oh yeah, estrogen's a carcinogen. Okay, side effects of hormonal manipulation. Androgens and anti-estrogen receptor drugs cause masculinizing effects in women. Chest and facial hair may develop, menstrual periods stop, and breast tissue shrink. For men and women receiving androgens, acne may develop, hyperkalemia, or hypercalcemia is common, not hyperkalemia. Excuse me. And liver dysfunction may occur with prolonged therapy. Women receiving estrogens or progestins prolonged or have irregular but heavy menses, fluid retention, and breast tenderness. Male and female patients who take estrogen or progestins are at increased risk for deep vein thrombosis, DVT. Feminine manifestations often appear in men who take estrogens, progestins, or anti-androgen receptor drugs. Facial hair thins or disappears, facial skin becomes smoother, body fat is redistributed, and gynecomastia, or breast development in men, can occur. Testicular and penile atrophy also occurs to some degree. Bam. Although sexual function may continue, achieving and maintaining an erection is much more difficult. Teach patients and families about these expected side effects. Encourage them to express their feelings about body image changes. Refer them for counseling if needed. Photodynamic therapy. Overview. Photodynamic therapy, or PDT, is the selective destruction of cancer cells through a chemical reaction triggered by different types of laser light. This newer type of therapy can be used to directly destroy some cancers, reducing the size of tumors, and then allow more complete tumor removal by surgery and shrink tumors in airways or the esophagus to relieve obstruction. PDT for cancer therapy is most commonly used for non-melanoma skin cancers, ocular tumors, GI tumors, and lung cancers located in the airways. It is under investigation for use as therapy combined with other treatment for brain tumors and prostate cancer. An agent that sensitizes cells to light is injected IV along with a dye. The most common agents used for this purpose are verteporfin and porphyrin sodium. These drugs enter all cells but leave normal cells more rapidly than cancer cells, usually within 48 to 72 hours. Most of the drug has collected in high concentrations in cancer cells. At this time, a laser light is focused on the tumor. The light activates a chemical reaction within those cells, retaining the sensitizing drug that induces irreversible cell damage. Some cells die and slough immediately. Others continue to slough for several days. Some lesions require only one exposure to the laser, and others may be re-exposed several days after the first treatment. Patient-centered collaborative care. The priorities for nursing care of the patient receiving PDT are teaching the patient and family to prevent complications and coordinating changes in the care environment for protection of the patient. The patient has general sensitivity to light for up to 12 weeks after the photosensitizing drug is injected. The most intense period of light sensitivity is after injection and before the laser treatment. During this time, the patient is at high risk for sunburn and eye pain. Teaching must begin before the patient comes for the injection. Specific instructions are listed in page 20 or chart 2411. Instruct the patient to bring clothing, hat, and eye protection to wear on the way home from the injection. Clothing should include gloves, shirts, or blouses with long sleeves and high collars, long pants, and socks to prevent burns from exposure to direct or indirect sunlight, including light through windows, and other intense light sources. Stress that the skin and eyes will remain sensitive for at least 30 days, even among people with very dark skin. Thus, the patient will need to use protective measures and be homebound for 1 to 3 months. Damn. Chart 2411, Patient and Family Education Guide, Photodynamic Therapy. Before photosensitization, bring protective clothing, e.g. shirts and long sleeves and high collars, long pants or skirt, gloves, socks, wide-brimmed hat, and UV protective sunglasses with you when you come to be injected with the photosensitizing agent. If possible, have someone else drive you home so that you can place a sheet or light blanket over yourself. Avoid leaving your home during daylight hours or anywhere from plan to avoid leaving your home during daylight hours. Cover all windows with light blocking shades or replace high wattage light bulbs with low wattage. It's awesome. It turns you into a vampire. Effects last from 1 to 3 months. To wear all protective clothing in sunlight in any form of high wattage lights. Drink plenty of water to prevent becoming dehydrated. Do not take any newly prescribed or over-the-counter drugs without contacting the physician who performed the photodynamic therapy. Some drugs make the light sensitivity even worse. Others interact with the photosensitizing drug. When you start to re-expose yourself to sunlight and other bright light, do so slowly. Start your exposing only about 1 inch of your skin to sunlight at a time. Start out with only 10 minutes and increase the time only by about 5 minutes each day. Remember that sunscreen will not prevent severe sunburn during this time. If you experience pain or blistering, notify the Photodynamic Therapy healthcare team. Continue to wear dark sunglasses even indoors until you no longer have eye pain when in a normally light. When you no longer are photosensitive, see an ophthalmologist to check whether your retina has been damaged. When the patient returns for the laser light therapy, the process may occur on an outpatient basis or for airway lesions. The patient may require several days as an inpatient in an intensive care unit. The nurse coordinates with all other members of the healthcare team in ensuring that the environment is safe for the patient. Lighting of all types is kept to a minimum. Even the use of a pen light or a sensor on a pulse oximeter can lead to burns. For a patient who has been injected with a photosensitizer. Electronic monitoring equipment should have the light intensity of the readout turned down as low as possible and not facing the patient. When the patient is transported, reducing hallway lighting and avoiding windows are essential. Any especially important member of the team to consult is the pharmacist. Any drug that the patient is prescribed should be considered for its photosensitizing properties. For example, certain antibiotics, tetracycline and erythromycin, increase photosensitivity, as do many antihypertensive drugs. When these drugs are taken by the patient receiving PDT, the intensity of the photosensitivity is increased and the patient's risk for harm is also increased. Immunotherapy, biological response modifiers, BSMs. Overview. Biological response modifiers, or BRMs, modify the patient's biologic responses to tumor cells. The BRMs in current use as cancer therapy are cytokines, which are small protein hormones made by white blood cells, cytokines made by macrophages, neutrophils, eosinophils, and monocytes are monokines. Cytokines produced by lymphocytes, especially the T lymphocytes, are lymphokines. Cytokines generally make the immune system work better. Okay, cytokines or cytokines enhance the immune system. Immune function plays an important role in cancer prevention. See chapters 19 and 23. Cytokines and other BRMs work as a cancer treatment by stimulating the immune system to recognize cancer cells and take actions to eliminate or destroy them. Some BRMs are also useful in a supporting role, such as colony-stimulating factors that stimulate faster recovery of bone marrow function after treatment-induced suppression. BRMs as cancer therapy. Two common types of BRMs used as cancer therapy are interleukins or ILs and interferons or INFs. Some agents can stimulate specific immune system cells to attack and destroy cancer cells. Other agents block cancer cell access to an essential function or nutrient. Table 24.6. Common biological response modifiers used as supportive cancer therapy. Response modifiers. Biological response modifiers used as supportive cancer therapy. Okay. Right. Agent. Sargrammastium or leucine protein. Cell types affected would be all granulocytes, neutrophils, eosinophils, monocytes, and macrophages. Indications would be chemotherapy-induced leukopenia. Then filgrastium or pneumogen, and that would be neutrophils, and that's chemotherapy-induced neutropenia indicated. Also, pegfilgrastium or Neulasta, that's also for neutrophils and chemotherapy-induced neutropenia. Epoetin alpha epigen erythrocytes procrit, also darbepoetin alpha or Aranesp. That would be chemotherapy-induced anemia, chemotherapy-induced fatigue, anemia induced by renal failure. Then oprelvecin or Numega, that would be for platelets, and it'd be chemotherapy-induced thrombocytopenia indicated. So back to the text, talking about now interleukins or ILs are a group of 27 known substances the body makes to help regulate inflammation and immune protection. Some are now synthesized as drugs. ILs help different immune system cells recognize and destroy abnormal body cells. In particular, IL-1, IL-2, and IL-6 appear to charge up the immune system and enhance attacks on cancer cells by macrophages, natural killer or NK cells, and tumor-infiltrating lymphocytes. Interferons, or INFs, are cell-produced proteins that can protect non-infected cells from viral infection and replication. Cancer-related functions of INF include the ability to slow tumor cell division, stimulate the growth and activation of NK cells, and help cancer cells resume a more normal appearance and function. Also inhibit the expression of oncogenes. INFs have been effective to some degree in the treatment of melanoma, hairy cell leukemia, renal cell carcinoma, ovarian cancer, and cutaneous T-cell lymphoma. One drug classified as a BRM that has a somewhat different action is thalidomide or thalamide, which reduces the level of tumor angiogenesis factor or TAF. TAF is needed to maintain blood supply to the tumor. When TAF is reduced, the tumor is poorly nourished and cancer cells die. This drug is approved for treatment of multiple myeloma. BRMs as supportive therapy. BRMs used for supportive therapy during cancer treatment are the colony-stimulating factors, table 24.6. These factors induce more rapid recovery of the bone marrow after suppression by chemotherapy. This effect has two benefits. First, when bone marrow suppression is shortened or less severe, patients are less at risk for life-threatening infections, anemia, and bleeding. And because the colony-stimulating factors allow more rapid bone marrow recovery, patients can receive their chemotherapy online or on time, and may even be able to tolerate higher doses, improving the curative outcome of chemotherapy. These agents, however, can stimulate the growth of leukemia or some lymphoma cells. Side effects of biological response modifier therapy. Patients receiving interleukins have generalized and sometimes severe inflammatory reactions. Fluid shifts and capillary leak are widespread, with edema forming in most tissues. Tissue swelling affects the function of all organs and can be life-threatening. Patients receiving high-dose BRM therapy should receive care in an intensive care or monitoring unit. The effects of BRM therapy are limited to the period of acute drug infusion and resolve when treatment is completed. Many BRMs induce symptoms of mild inflammation during and immediately after receiving the drug, including fever, chills, rigors, and flu-like general malaise. Problems are worse when higher doses are given, but they seem to become less severe over time. Fever is treated with acetaminophen. Patients with severe rigors or severe shaking chills are managed with meperidine or Demerol. Interferon therapy causes peripheral neuropathy, similar to that found in patients who have long-standing diabetes mellitus. Some of the problems resulting from the neuropathy include decreased sensory perception, visual disturbances, decreased hearing, unsteady balance and gait, and orthostatic hypotension. It is not known whether the neuropathy is temporary or permanent. See the discussion of peripheral neuropathy on page 430 to 431. Skin rashes, dryness, itching, and peeling occur with many types of BRM therapy. The skin problems are more severe at higher doses, and when more than one type of BRM is used at the same time. These reactions are temporary but can cause much discomfort and distress to the patient. Advise patients to apply moisturizers, perfume-free, to the skin and to use mild soap to clean the skin. Involved areas should be protected from the sun with clothing or the use of sunscreen agents. Inform patients to avoid swimming and to refrain from using topical steroid creams on affected areas. Gene therapy. Gene therapy as a cancer treatment is experimental. One method of using gene therapy for cancer is to render the tumor cells more susceptible to damage or death by other treatments. Inserting a viral enzyme gene into brain tumor cells makes them more susceptible to being killed by antiviral agents. Other techniques involve inserting human leukocyte antigen, or HLA, genes different from the patient's own HLAs into the tumor cells. This technique makes the patient's immune system cells better able to recognize the cancer cells as foreign and take steps to eliminate or destroy them. Both methods of gene therapy for cancer have shown some success in early phase clinical trials, but are not approved treatments. Some immune system cells are capable of attacking and killing cancer cells. This ability is increased when more of certain cytokines, such as IL-2, are present. Some gene therapy involves inserting additional genes for cytokines into the patient's own immune system cells. These charged up cancer-fighting immune system cells remain active for up to 6 months and can participate in cancer cell killing episodes. Targeted therapy. Overview. Targeted therapies combine aspects of gene therapy and immunotherapy. These therapies take advantage of one or more differences in cancer cell growth or metabolism that are either not present or only slightly present in normal cells. These differences are a result of specific gene expression in cancer cells. These differences are a result of specific gene expression in cancer cells. Agents used as targeted therapies often are antibiotics that work to disrupt cancer cell division in one of several ways. Some of these drugs target and block growth factor receptors, especially the epithelial growth factor receptors, EGFRs, or the vascular endothelial group factor receptors, or the VEGFRs. When a cancer cell's growth depends on having the growth factors bind to its specific receptor, blocking the receptor slows or eliminates the cancer cell's growth. Other agents for targeted therapy may be antibodies, antibodies directed against cellular substance needed by the cancer cell for growth, or a substance in the cell's signal transduction pathway that is important in turning on certain genes for cell growth. Targeted therapy can block these pathways so that the signal for turning on cell division genes does not get through to the cell's nucleus. Many drugs for targeted therapy have been approved as treatment for certain cancers. It is important to remember, however, that these drugs will not work unless the cancer cell overexpresses the actual target substance. Thus, not all patients with the same cancer type would benefit from the use of targeted therapy. Each person's cancer cells are evaluated to determine whether the cells have enough of a target to be affected by targeted therapy. An example of targeted therapy is trastuzumab, or Herceptin. This EGFR antibody binds the excessive amounts of a certain type of EGFR produced by cancer cells in response to the activation of the HER2/neu gene. Binding this receptor prevents the division of cancer cells and makes them more easily killed by immune system cells. Another monoclonal antibody, rituximab, or ridazan, has a similar effect in some types of lymphoma. Another example of a targeted therapy drug is imatinib mesylate, or Gleevec. This drug binds to the energy site of the enzyme tyrosine kinase and prevents its activation. The drug is most useful in cancers that overexpress the ABL1 oncogene, such as Philadelphia chromosome positive chronic myeloid leukemia. Table 24/7 lists some agents
currently used for targeted cancer therapy. Side effects of targeted therapy. Allergic reactions are an issue in patients receiving monoclonal antibodies. Most of these antibodies were developed in animals and may express some animal proteins. More recently, much of the animal portion of these antibodies was removed. Thus, the risk for allergic reactions is reduced but not eliminated. Patients receiving antibodies over time may develop their own antibodies to the drugs, making them less effective and possibly causing severe inflammatory or allergic reactions. In addition, the EGFR and the VEGFR antibodies bind to those specific receptors when the receptors are on normal tissue. Thus, side effects occur in those tissues that normally express EGFR, such as the skin, mucous membrane, and lining of the GI tract. Oncologic emergencies. Cancer is a chronic disease. However, a number of acute conditions associated with cancer and its treatment can occur. These conditions or complications often require immediate intervention and are thus oncologic emergencies. Early diagnosis of such conditions is essential to avoid life-threatening situations. The role of the nurse is to plan and implement interventions to prevent and detect these complications early for immediate treatment. Table 24/7, examples of targeted therapy agents. I'm not going to read all these, there's just too many. And it's not helpful. Okay. So, sepsis and disseminated intravascular coagulation. Pathophysiology. Sepsis or septicemia is a condition in which organisms enter the bloodstream. Septic shock is a life-threatening result of sepsis and a common cause of death in patients with cancer. Patients with cancer are at risk for infection and sepsis because their white blood cell counts are often low and their immune function is usually impaired. Chapter 39 describes the pathophysiology of sepsis and septic shock. Disseminated intravascular coagulation, or DIC, is a problem with the blood clotting process. DIC is triggered by many severe illnesses, including cancer. In patients with cancer, DIC is caused by sepsis, often a gram-negative infection, by the release of thrombin or thromboplastin clotting factors from cancer cells, or by blood transfusions. DIC is most often seen in leukemia and in adenocarcinomas of the lung, pancreas, stomach, and prostate. Extensive abnormal clotting occurs throughout the small blood vessels of patients with DIC. This widespread clotting uses up the existing clotting factors and platelets. This process is followed by extensive bleeding. Bleeding from many sites is the most common problem and ranges from minimal to fatal hemorrhage. Clots block blood vessels and decrease blood flow to major body organs and result in pain, stroke-like manifestations, dyspnea, tachycardia, oliguria, decreased urine output, and bowel necrosis or tissue death. Chapter 39 describes in depth the collaborative management of sepsis-induced DIC. Patient-centered collaborative care. DIC is a life-threatening problem and has a high mortality rate, even when proper therapies are instituted. Thus, the best plan for care of sepsis and DIC is prevention. Identify those patients at greatest risk for sepsis and DIC. Practice strict adherence to aseptic technique during invasion procedures and during contact
with non-intact skin and mucous membranes in immunocompromised patients. Teach patients and family members the early manifestations of infection and sepsis and when to seek medical assistance. When sepsis is present and DIC is likely, management focuses on reducing the infection and halting the DIC process. IV antibiotic therapy is initiated. During the early phase of DIC, anticoagulants, especially heparin, are given to limit clotting and prevent the rapid consumption of circulating clotting factors. Cryoprecipitated clotting factors are given when DIC has progressed and hemorrhage is the primary problem. See Chapter 39 for a more detailed discussion of the management of DIC. Syndrome of inappropriate antidiuretic hormone. Pathophysiology. In healthy people, antidiuretic hormone, or ADH, is secreted by the posterior pituitary gland only when more fluid or water is needed in the body, such as when plasma volume is decreased. Certain health problems induce ADH secretion when not needed by the body. Cancer is the most common cause of the syndrome of inappropriate antidiuretic hormone, or SIADH. The cancer most commonly causing SIADH is carcinoma of the lung, especially small cell lung cancer. But SIADH may occur in other types of cancer, especially when tumors are present in the brain. Some tumors actually make and secrete ADH, whereas others stimulate the brain to make and secrete ADH. Drugs often used in patients with cancer also can cause SIADH, e.g. morphine sulfate and cyclophosphamide. In SIADH, water is reabsorbed to excess by the kidney and put into systemic circulation. The increased water causes hyponatremia, or decreased serum sodium levels, and fluid retention. Mild manifestations include weakness, muscle cramps, loss of appetite, and fatigue. Serum sodium levels range from 115 to 120 millicuries per liter. Normal range is 135 to 145. More serious problems occur when even more water is retained, including weight gain, nervous system changes, personality changes, confusion, and extreme muscle weakness. As the sodium level drops toward 110, seizures, coma, and death may follow. Patient-centered collaborative care. SIADH is managed by treating the condition and the cause. Nursing interventions for patients with SIADH aim to ensure patient safety, restore normal fluid balance, and provide supportive care. Management includes fluid restriction. Sometimes total fluid intake is reduced to 1 liter a day. Increased sodium intake and drug therapy. The drug most often used is demeclocycline, which is taken orally. This drug, an antibiotic, works in opposition to ADH. A second method for managing SIADH is to reduce or eliminate the underlying cause. Immediate cancer therapy, usually either radiation or chemotherapy, can cause such tumor regression that ADH production returns to normal. Patient safety includes preventing fluid overload from SIADH from becoming worse, leading to pulmonary edema and heart failure. Any patient with SIADH, regardless of age, is at risk for these complications. The older adult, or one who has coexisting cardiac problems, kidney problems, pulmonary problems, or liver problems, is at greater risk. Monitor for indicators of increased fluid overload, increased pulse quality, increasing neck vein distension, presence of crackles in lungs, increasing peripheral edema, reduced urine output, at least every 2 hours. Check that stuff. Pulmonary edema can occur very quickly and can lead to death. Notify the healthcare provider of any change that indicates the fluid overload from SIADH either is not responding to therapy or is becoming worse. See Chapter 65 for a more detailed discussion of the patient with SIADA. Spinal cord compression. Pathophysiology. Spinal cord compression, SCC, and damage occur either when a tumor directly enters the spinal cord or when the vertebrae collapse from tumor degradation of the bone. Tumors may begin in the spinal cord but more often spread from other areas of the body such as the lung, prostate, breast, and colon. SCC often causes back pain before neurologic deficits occur. Neurologic problems are specific to the level of spinal compression and can lead to paralysis. If paralysis occurs, it is usually permanent. Patient-centered collaborative care. Early recognition and treatment of the spinal cord compression are key to a positive outcome. Assess the patient for neurologic changes consistent with spinal cord compression. These include back pain, muscle weakness, or a sensation of heaviness in the arms or legs, numbness or tingling in the hands or feet, loss of ability to distinguish hot and cold, and an unsteady gait. Depending on how low the compression occurs, constipation, incontinence, and difficulty starting or stopping the stream of urine also may be present. A new onset of any of these problems is cause to consider the possibility of SCC. Teach patients and families the manifestation of early SCC and instruct them to seek help as soon as problems are apparent. If the problem is suspected, magnetic resonant imaging is usually ordered immediately. Treatment is often palliative. Usually high-dose corticosteroids are given first to reduce swelling around the spinal cord and relieve symptoms. High-dose radiation may be given to reduce the size of the tumor in the area and relieve compression. Radiation also may be used along with chemotherapy to treat the total disease. Surgery may be performed to remove the tumor from the area and arrange the bony tissue so less pressure is placed on the spinal cord. External back or neck braces may be used to reduce the weight borne by the spinal column and to reduce pressure on the spinal cord or spinal nerves. Hypercalcemia, pathophysiology. Hypercalcemia, increased serum calcium level, occurs most often in patients with bone metastasis. Cancer in bone causes the bone to release calcium into the bloodstream. In patients with cancer in other parts of the body, especially the lung, head, and neck, kidney, or lymph nodes, the tumor secretes parathyroid hormone, causing bone to release calcium. Decreased mobility and dehydration worsen hypercalcemia. Early manifestations of hypercalcemia include fatigue, loss of appetite, nausea, vomiting, constipation, and polyuria. Increased urine output. More serious problems include severe muscle weakness, loss of deep tendon reflexes, paralytic ileus, dehydration, and electrocardiographic changes. The severity of manifestations depends on how high the serum calcium level is and how quickly it develops. Patient-centered collaborative care. Cancer-induced hypercalcemia develops very slowly for many patients, which allows the body time to adapt to this electrolyte change. As a result, symptoms of hypercalcemia may not be evident until the serum calcium level is greatly elevated. Because adaptation does occur, cancer-induced hyperkalemia is treated only when manifestations are present. Oral hydration alone may be enough to reduce the serum calcium and relieve symptoms. Normal saline is used when parenteral hydration is needed. Many drugs lower serum calcium levels. Some agents, such as oral glucocorticoids, calcitonin, diphosphonate, gallium nitrate, and mithramycin, lower levels quite dramatically. These drugs do not cure hypercalcemia, but instead reduce serum calcium levels temporarily. When cancer-induced hypercalcemia is life-threatening or occurs with renal impairment, dialysis can temporarily reduce serum calcium levels. Superior vena cava syndrome, or SVC. Pathophysiology. Superior vena cava syndrome, SVC syndrome, occurs when the SVC is compressed or obstructed by tumor growth or by the formation of clots in the vessel, figure 24.3. SVC compression can lead to a painful and life-threatening emergency, usually in patients with lymphomas and lung cancer. Patients with cancer of the breast, esophagus, colon, and testes may also be affected. The manifestations of SVC syndrome result from the blockage of blood flow in the venous system of the head, neck, and upper trunk, venogram of the upper extremities, and the superior vena cava show a stricture or an occlusion blocking blood flow. Early manifestations occur when the patient arises after a night's sleep and include edema of the face, especially around the eyes, and tightness of the shirt or blouse collar. Figure 24.3 shows compression of the superior vena cava. Okay. So, early manifestations occur when the patient arises after a night's sleep and include edema of the face, especially around the eyes, and tightness of the shirt or blouse, also called Stokes sign. As the compression worsens, the patient develops edema in the arms and hands, dyspnea, or erythema of the upper body, and epistaxis, or nosebleeds. Late manifestations include hemorrhage, cyanosis, mental status changes from lack of blood to the brain, decreased cardiac output, and hypotension. Death results if compression is not relieved. Patient-centered collaborative care. SVC syndrome is a late-stage manifestation. The tumor is usually widespread. High-dose radiation therapy to the medication area may be used to provide temporary relief. Surgery is rarely performed for this condition because the tumor may have increased intrathoracic pressure to such a level that it may be impossible to close the chest after the procedure. Wow. A metal stent can be placed in the vena cava in an interventional radiation department to relieve swelling. Follow-up angioplasty can keep the stent open for a longer period. See Chapter 38 for more information on stenting procedures. The best treatment results occur when SVC syndrome is in the early stages. Assess each patient for manifestations of SVC syndrome and notify the physician. Tumor lysis syndrome. Pathophysiology. In tumor lysis syndrome, or TLS, large numbers of tumor cells are destroyed rapidly. Their intracellular contents, including potassium and purines, DNA components, are released into the bloodstream faster than the body can eliminate them. Unlike other oncologic emergencies, TLS is a positive sign that cancer treatment is effective. Severe or untreated TLS can cause severe tissue damage and death. Serum potassium levels can increase to the point of hyperkalemia, causing severe cardiac dysfunction. The large amounts of released purines are converted in the liver to uric acid and released in the blood, causing hyperuricemia. This uric acid crystals precipitate in the kidney, forming sludge in the kidney tubules. This effect blocks the tubules and leads to acute renal failure. TLS is most often seen in patients receiving radiation or chemotherapy for cancers that are very sensitive to these therapies, including leukemia, lymphoma, small cell lung cancer, and multiple myeloma. Patient-centered collaborative care. Prevention through hydration is the best management for TLS. Hydration alone can dilute the serum potassium level and increase the kidney filtration rate. As a result, urine flows through the kidney at a greatly increased rate. This action prevents the precipitation of uric acid crystals, increases the excretion of potassium, and mechanically flushes any renal tubular sludge. With tumors known to be very sensitive to cancer therapy, instruct patients to drink at least 3,000 milliliters or 5,000 milliliters is more desirable of fluid the day before, the day of, and 3 days after the treatment. Some fluids should be alkaline, sodium bicarbonate, to help prevent uric acid precipitation. Stress the importance of keeping fluid intake consistent throughout the 24-hour day and help patients draw up a schedule of fluid intake. Because some patients have nausea and vomiting after cancer therapy and may not feel like drinking fluids, stress the importance of following the antiemetic regimen. Instruct patients to contact their healthcare provider or a cancer clinic immediately if nausea and vomiting prevent adequate fluid intake so they can be started on parenteral fluids. Management becomes more aggressive for patients who become hyperkalemic or hyperuricemic. In addition to increased fluid intake, oral or parenteral, diuretics, especially osmotic types, are given to increase urine flow through the kidney. These agents are given with caution because patients must not become dehydrated. Drugs that increase the excretion of purines, such as allopurinol or Alloprim or Xyloprim, or resburicase or Elitech, are given to reduce serum potassium levels for mild to moderate hyperkalemia. Sodium polystyrene sulfonate can be given orally or as a retention and enema. This treatment does not immediately reduce serum potassium level. For more severe hyperkalemia, IV infusion containing glucose and insulin may be given. Patients who have severe hyperkalemia and hyperuricemia may need dialysis. NCLEX Examination Challenge. The client being treated for lung cancer reports new onset back pain and asks for pain medication for this problem. What questions should the nurse ask about this issue? A. What kinds of pain medication are you taking now, and how often are you taking them? B. Do you have any numbness or tingling in your hands or feet or difficulty urinating? C. Can you relate this new back pain to any position or activity that you are performing? And D. Have you tried applying heat to your lower back and avoiding bending or lifting? Okay, not sure. Alright, get ready for NCLEX's examination. Key points. Review these key points for NCLEX examination client needs category. A safe and effective care environment. Use a septic technique during care for open skin areas or any invasive procedure. Use good hand washing techniques before providing any care to a patient who is neutropenic. Use bleeding precautions for any patient with thrombocytopenia. Position shields properly when patients in inpatient settings are receiving brachytherapy. Use appropriate personal protective equipment, gowns, gloves, masks, eye protection when mixing or administering chemotherapeutic agents, and when handling excreta of a patient receiving chemotherapy. Health promotion and maintenance. Teach patients receiving radiation therapy path. See chart 24.2. Because of disease or therapy. Patient and family about the manifestations of infection. Seek medical advice. Teach patients at risk for bleeding precautions to take to avoid injury. Psychosocial integrity. Allow the patient the opportunity to express his or her feelings regarding the diagnosis of cancer or the treatment regimen. Encourage the patient to verbalize feelings about changes in appearance resulting from cancer therapy. Explain all procedures, restrictions, and follow-up care to the patient and family. Offer alternative therapies for relaxation, pain reduction, and distraction, such as massage, music therapy, and guided imagery. Help patients use strategies to improve their appearance when alopecia occurs. Refer patient and family members to local cancer resources and support groups. Physiological integrity. Assess the venous access device at least every Physiological integrity. Assess the venous access device at least every 30 to 60 minutes during chemotherapy administration. Assess the patient receiving chemotherapy for manifestations of infection at least every 8 hours. Inspect the oral mucosa of patients with neutropenia at least every 8 hours. Report any temperature over 100 degrees Fahrenheit in a patient with neutropenia. Follow agency guidelines for obtaining cultures and diagnostic tests or starting anti-infective therapy in the patient with neutropenic fever. Instruct the patient and family in the manifestations of complications and when to seek assistance, and pace non-urgent healthcare activities to reduce the risk for fatigue for patients with anemia. The end. Chapter 24. Care of patients with cancer. That was a long one.